Apologies for these technical inconveniences, but the computer there was not working, so we had to find another way. So I'm very happy to talk to you about fetal megacystis. This is a slightly different topic from the previous one, because we are talking about the fetus and not about the mother. So over all the congenital defects, we see that in relation to neonatal or childhood death, genitourinary problems are quite favorable, because they are not accompanied by a major death rate. And on the contrary, if we look at the capability of ultrasound to detect these anomalies, they lean themselves for a good detection by ultrasound. I will start by talking about megacystis, and in particular early megacystis, because this is the condition, the genitourinary problem that we will encounter more often in early gestation. The prevalence is 1 in 1,600. We know that is associated with trisomies, especially trisomy 18, and together with 13 in 30% of the cases. And we know from the literature, from the older literature, that when the bladder length is in between 7 and 15 millimeters, there is a very high chance of resolution, about 90%, whereas where the bladder length is more than 15 millimeters, there is no chance of spontaneous resolution, and very often we will be faced with a lower urinary tract obstruction, or LUTO. Which is the natural history of LUTO? First of all, we will see a megacystis, a dilatation of the fetal bladder, accompanied by hydronephrosis. And then in the cascade of events, there will be oligohydramnios, which means that there will be no urine reaching the amniotic compartment. And because of this, and because of the ensuing hypoplastic lungs, this condition is associated with a very high perinatal mortality, about 50%, and accounts for 60% of all pediatrics renal transplants, and for 25 to 30% of all cases of renal insufficiency. Let's have a quick look at the embryology of the lower urinary tract. And we can see that the formation starts already from 9 weeks. And we know that there is a major difference between females and males. And the embryologic abnormality gives rise to posterior urethral valve, which is in many cases which is the most common background of LUTO, is thought to represent either an anomalous insertion of the mesonephric duct into the urogenital sinus, preventing normal migration of these ducts in their anterior fusion, or a consequence of an abnormality of the cloacal membrane. Talking of the anatomical background of LUTO, which accounts for 2.2 in 10,000 births, we see that the most common anomaly in males is posterior urethral valves that account for 63% of all the LUTO cases. And in women, the most common anomaly is the urethral atresia, much more severe, obviously, and with bad consequences. And then we have 7% of cases of a milder form, which is urethral stenosis, and then the remaining 20% are unspecified or prune belly, the so-called prune belly syndrome. And this is according to this paper by Meli and others. If we look at the prenatal ultrasound findings in LUTO, well, apart from megacystis, the keyhole sign, which is the dilation of the proximal portion of the urethra is a very known one. Then hydronephrosis is also very common. And then when the situation progresses and deteriorates, we can see dilated ureters, cystic appearance of the renal parenchyma, and then oligohydramnios with all the typical signs of, for instance, also of dolichocephaly. I will report you on a number of studies that we performed in the Netherlands, where we collected all cases of megacystis in pregnancy, known at all academic centers over a long period of time. In total, they were 541, 233 early, and 308 late megacystis. In 418 fetuses, we got to a final diagnosis. And as you can see, in termination of pregnancies occurred in a larger number of cases, 188. In 50 cases, we had intrauterine fetal deaths, and 68 neonates died after birth. And in total, 43% of fetuses survived and became live-born. If we look at what happened in the cases where we got to a final diagnosis, genetic causes were found in 33%, no obstruction after birth, which means spontaneous resolution, was found in 14% of the cases, and a true lower uterine tract obstruction was therefore diagnosed in 53% of the cases. So when we are faced with the finding of a megacystis, there are a number of questions that we have to answer. Is it a real LUTO? Are there other possible backgrounds, etiologies? What is the diagnostic value of the ultrasound parameters that we see? Can we predict spontaneous resolution or mortality and long-term prognosis? And which instrument can be used to select the best candidate for potential in utero treatment? Who are they and when should we offer this? So let's go stepwise. First of all, we need to do a very accurate anatomic survey, because we know that in about 30 to 40% of the cases, there are associated anomalies with the megacystis, and you can see here all the anomalies associated, especially other renal, but also cardiac in 40% of the cases, and multiple anomalies and anorectal malformation in about 4% of the cases. Second step, genetic investigation, because we know that in 20% of LUTO cases, there are associated trisomies, especially 18, as I told you. But apart from the chromosomal anomalies, there are also other genetic conditions that can be associated, like, for instance, all kinds of genetic syndromes that I will just spare to you from naming them all, and other miscellaneous conditions like Factor, Bacter, of cloacal anomalies, Currarino syndrome, body stalk anomaly, and even infections. Another important observation is the gender of the fetus. And as I told you, if it's a male, most likely will be a posterior urethral valve, whereas in a female, we may be confronted with urethral atresia, but also the microcolon megacystis hypoperistalsis syndrome could play a role, or persistent cloaca anorectal malformation, or caudal regression syndrome. So let's have a look at these rare conditions and look at the differential diagnosis. So as far as cloacal dysgenesis and anorectal malformation are concerned, as I said, they are mostly females. They have a normal karyotype, and we could use a search of intestinal enzymes in the amniotic fluid that could be diagnostic. Other hints that we could have is that the persistent cloaca generally presents with a very enlarged bladder prior to 16 weeks and multiple cystic structure in the lower abdomen that are due to the other organs that are a part of the cloacal tube, and will often show presence of debris within the cloaca and intraluminal calcification within bowel loops due to the communication between bowel and the urinary tract. Other possible anomalies when the karyotype is normal and there is normal amniotic fluid are the caudal regression syndrome, very common in the, well, common in diabetic mothers. And in this case, we will see that there are vertebral and lower extremity defects and sometimes also bladder extrophy. In this case, we will not have a megacystis, obviously. And then the other important differential diagnosis is this MMIHS syndrome, the megacystis microcolon-intestinal hyperperistalsis, presence in patients with normal to increase amniotic fluid and dilated bladder with a thin wall, as well as dilated loops of bowel, as you can see here. In that case, it would be very important to have a more advanced genetic investigation. So if we look in our group to which was the outcome of the early megacystis, in total 142 cases, 20% had a normal voiding after birth, so were a spontaneous resolution. 37% were real LUTO, and of these we can see that the majority were posterior urethral valve or urethral stenosis, being twice as much than atresia, and complex megacystis, meaning megacystis plus other congenital anomalies or chromosomal anomalies, was present in 43% of the cases. In early megacystis, the use of this triad, nuchal translucency, longitudinal bladder diameter of less or more than 12 millimeter, and the presence of umbilical cystic cyst in the cord, could really help us discriminating between fetuses theoretically eligible for fetal treatment with a sensitivity and specificity of 92% and 74% respectively. And why am I now mentioning an ideal longitudinal bladder diameter of 12 millimeters instead of 15? Because in our study, this was the best cutoff, not 15, but 12 millimeter, and the critical gestational age for an uneventful resolution, which means a resolution that will not leave sequelae, was 23 weeks. And now we move to talk, I don't understand why it's going so fast, to the megacystis in the second and third trimester. Sorry. So these are the signs that I already described to you. We had 143 cases, and as you can see, this is a kind of an ideal flow chart. If the megacystis is isolated and there is normal amniotic fluid, we could think of this MMHIS syndrome, or if the fetus is particularly big, large, overgrowth syndrome. Whereas if we find a cardiac defect, we could think of a 22q11.2 deletion, the DJOR. We could think of an association of LUTO with cardiac defect, or we could think of a Bacter syndrome. If none of this is present, then we should conclude that we are dealing with an isolated LUTO. And then the question is, if we diagnose isolated LUTO, how can we improve our diagnostic accuracy that we are really dealing with the LUTO? And we propose these 5 parameters, which are severe megacystis, bilateral ureteral diameters, oligoanhydramnios, fetal sex, and referral before the 28 weeks with some points for them. And we saw that these 5-point score, let's say parameter score, is much better than the classic triad megacystis, keyhole, and hydronephrosis in predicting the true presence of a lower urinary tract obstruction. And as you can see, this can improve based on the area under the curve from 63.63 to 0.84. And we can, therefore, with a score of more than 9.5, assess with 96% accuracy that there is a LUTO with a sensitivity of 78% and a positive predictive value of 96. And then another important aspect, well, we have now decided that it's a real LUTO, but then it's very, very important to be able to distinguish between posterior urethral valves with a better prognosis and eligible for treatment in principle, and urethral atresia that, as I told you, has a very, very bad prognosis. So we don't want to submit these fetuses to intrauterine surgery. And we looked at the mean longitudinal bladder diameter in these 2 cases, and we calculated the Z scores, and we could see that a Z score of about 4 is predictive of posterior urethral valve, whereas a Z score of twice as much, 8.83, a much larger bladder, therefore, is predictive of urethral atresia. So another aspect is how can we predict adverse outcome if we see the megacystis late in pregnancy? And from multivariate analysis, we could see that bladder volume at the diagnosis, together with the gestational age at onset of hydramnios, is a very good predictor. And the gestational age at first appearance of oligoanhydramnios gives us optimal cutoff 26 weeks of gestation. In other words, if we have a bladder volume of more or equal 5.4 centimeter to the third and oligoanhydramnion before 20 weeks, this will be a severe LUTO. Whereas if there is a normal amniotic fluid at 20 weeks, this will be a moderate LUTO, and we can see here the respective survival curves. And if there is a normal amniotic fluid at 26 weeks, this is a mild LUTO, and you can see here that the chance of survival is much higher than in the other 2 cases. And this distinction between degrees of severity also tell us something about the intactness of the renal function. And we see that in severe LUTO, glomerular filtration is abnormal in 44% of the cases, whereas in moderate in 30% of the cases, and in mild LUTO only in 11% of the cases. So, which are the best candidates for therapy? In early megacystic, those who have a normal mucotranslucency, a normal genotype, those who have a longitudinal bladder diameter more than 20 millimeters, but less than twice the gestational age in length. For instance, if they are 15 weeks, it should be less than 30, and that have no got umbilical cord cysts, because as I told you, they are highly associated with other malformations like cloacal dysgenesis. In late megacystis, oligohydramnios before 26 weeks is a good prognostic sign. Sorry, it's a bad prognostic sign. And bladder volume more than 5.4 centiliter as well. So talking of fetal therapy, there are some techniques that have been described in the literature, from the simple bladder puncture ones that could be resolutive in some cases, and usually in the workup of the megacystis, this is always done, but it could not be resolutive because the megacystis could form itself again. Then there is the more known, the most common fetal therapy, which is the insertion of a catheter, a percutaneous insertion of a catheter. And this was the so-called Fetal drain. This was the subject of a study, the LUTO study, which was stopped because they couldn't recruit women. And although vesicoamniotic shunts improves perinatal survival, this is at the expenses of residual risk of poor long-term postnatal renal function. And that was also the reason why the trial was stopped. A new attempt to correct the situation is by doing a cystoscopy, an intrauterine fetal cystoscopy, and applying a shunt. Well, this seems to be quite promising, although there is a modest long-term survival and adequate preserve normal renal function as compared to the previous technique, and technically is quite difficult. There may be some advantage, but it's not that convincing anymore. So in conclusion, in case of megacystis, rule out complex cases, those in early gestation with enlarged T, anomalies or megacystis more than twice the gestational age numerically, by genetic investigation detailed scans. A simple early megacystis with a longitudinal bladder diameter less than 12 millimeters will resolve in 70% of the cases. Therefore, don't rush into termination, but repeat the examination 2 weeks later. The cutoff in terms of gestational age for an uneventful resolution in early megacystis is 23 weeks. In late megacystis, increased diagnostic accuracy is given by the use of the 5 parameters. Z-scores of longitudinal bladder diameter can help us distinguishing between a posterior urethral valve with a more favorable prognosis and urethral atresia. And if oligoanhydramnia was already present before 26 weeks, this is a very bad prognostic sign, and we are really dealing with a severe LUTO. And the efficacy and type of antenatal therapy for LUTO and the best gestational age are still a matter of debate, and a sector where research, much more research is requested. Thank you very much.
Thank you, Professor Katia, for this nice, valuable talk. Thank you.
Thank you very much, Professor Katia, for this comprehensive and illustrative lecture.
Okay.
I would like to ask you just a question. I would like your comment, please. I would like to listen from you an honest answer about whether we try or not to try to treat or give an intrauterine therapy for those cases with lower urinary tract obstruction, megacystis, I mean, especially those that we diagnose in the earliest stages of the first trimester with a huge bladder.
Well, I think that in those cases that we diagnose in the first trimester with a huge bladder, there is no point, and for huge bladder, I mean more than 12 millimeters, there is no point in giving hope to the patient because we know that no resolution will occur. I would, for the sake of security, repeat 2 weeks later. And if it's still there, and it's very likely that will still be there, then I would counsel the patient very negatively and not give her false hope.
So the answer is to terminate after 2 weeks if we found that still the same problem.
Yes, that's the answer.
Okay, thank you very much.